Okay, it's now going to record, huh? Good morning, Piyush. Okay, so can you see the slides? Or not yet?
Yes, ma'am.
You can see the slides. Oh, slides have gone. The whole classroom has changed. Just a minute, huh? Let me try to get the slides. I'm in a meet without the slides. The tab got closed. Okay, while the tab is opening. So do you remember what was Amitabh Bachchan's problem? What did he keep? No, not perforation peritonitis. Throughout the movie, what was he worried about? Constipation. Yeah, he was constantly worried about bowels. हो गया तो, आया तो, thin, thick, hard, soft. So many problems he had, isn't it? All related to bowel. So that is a classical case of inflammatory bowel disease. No, irritable bowel syndrome. Oh, the whole classroom has changed. Okay, can you see? Can you see?
Yes, ma'am.
Yes, ma'am.
Okay, great. So today we are going to do chronic diarrhea and malabsorption, but I will be talking a little bit about celiac disease and sprue also. Oh, the whole interface has changed. They should have warned us. Anyway, how do I keep changing the slides? So remember I told you acute diarrhea, chronic diarrhea, duration less than 2 weeks, more than 4 weeks. 90% in acute are infections. Most are non-infectious in chronic diarrhea. Empiric therapy in acute diarrhea is okay. And in chronic diarrhea, it's a strict no-no. I don't know why it's not opening with Google Slides. Anyway, so basically why I did infections again was evaluation and treatment of each is different. That is very important to understand. Okay. I just hope the slides change one at a time. If they run, then my whole class will spoil. Anyway. No, it is. Can you just give me half a minute? Let me try again. Share a tab. But how do I change the slides? I've stopped presenting, huh? Now let me present again. And it's not open with Google Slides. This is better. Okay, so this let me close. And थोड़ा गड़बड़ हो गया आज. Yeah, this is better. Okay, now I can change the slides. Can you see?
Yes, ma'am.
So definitions
ma'am.
we said, I'm not discussing it again. Acute less than 2 weeks, persistent 2 to 4 weeks, and chronic 4 weeks, more than 4 weeks. And acute diarrhea and chronic diarrhea the duration, the etiology, and the treatment part. And evaluation of treatment of both is completely different. Dysentery also, I'm going to skip this slide. So chronic diarrhea. Now we come to the problem of today. Secretory causes, osmotic causes, steatorial causes, inflammatory causes, motility causes, factitial causes. What is factitial? Anybody? Factitious is fake. Okay, so somebody is chronically taking laxatives, they will have factitious diarrhea. This motility, there is a problem with the innervation. The motility sometimes is psychologically controlled also. Many people, they are so obsessed about the bowels, they will be always unhappy abdomen, unhappy, always unhappy. Everybody will have one odd grandparent or parent in the family. Indians particularly are very obsessed about bowels. 2 times हो गया, 3 times हो गया, clear नहीं हुआ. This is a common complaint you will face in OPDs. Where will the stool go? There is only one way it can come out, and it will come out eventually. What is steatorial? If there is steatoria, that means too much unabsorbed fat, undigested unabsorbed fat in the fecal mass. So fat is lighter than water. So this steatorial cause, obviously if there are lipase deficiencies, chronic pancreatitis or intestinal hurry or biliary problems, there is a bile finally emulsifies the fat, isn't it? Only after that the lipase can act on it. So if there is less bile or less lipase, then there will be undigested fat in the food, which will pass out in the stool, make them bulky, make them float on top of water, light, and that is called, and may stick to the pan, stick to the side. So that is steatoria. Okay. Have your people understood? Somebody unmute and tell me. Yes, no, chat.
Yes, ma'am.
Good. So we'll take them one by one. Remember, first is secretory. So I will keep highlighting and I will just list them out once for you, so that when you revise and look at this lecture, you will be, sometimes a long question can come on chronic diarrhea. So secretory causes. Secretory, if you take laxatives, which laxatives will cause more secretion into the gut? You people are fresh from pharmacology?
Osmotic laxative.
Huh? Very good. Very good. Like lactulose. They will cause more secretion and loose stools. Then drugs, alcohol and toxins. They can cause chronic diarrhea. Somebody is on metformin. It can cause chronic loose stools. Alcohol can cause chronic diarrhea, and certain toxins if they are being ingested, especially professional space, painters, they may have chronic diarrheas. Some specific infections, remember we said amoebiasis can go on for months to years, so they can also cause chronic diarrhea. And then they're idiopathic, cause not found despite lots of investigations. Bowel resections, fistulas, partial obstructions, these can also create a blind loop or intestinal hurry. If the ileum is resected, 10 feet of the ileum is resected. It is how many? 20, 25 feet or so, isn't it? So if 10 feet is rejected, the food bolus will pass right through the ileum quickly. There is not much in length. It's a long distance runner made to do a 100 meters race. He will finish it very quickly. So that is what happens when there is bowel resection. Fistula, opening of one viscus into another viscus or to the exterior. So this is enteroenteral fistulae. So they will again bypass and go through the fistula rather than the entire length of the intestine. And hormone producing tumors, typically apodomas, all of our neuroendocrine tumors. They're a different category, carcinoid, etc. They can produce chronic diarrhea. Addison's disease. Well, how will Addison's cause chronic diarrhea? Mineralocorticoid deficiency. Along with it, there is also steroid deficiency. And all these hormones, especially the mineralocorticoids, they are what are they finally? They are your catecholamines, etc. If there is a deficient, again you may have motility disturbances. Okay. Mineralocorticoid is your aldosterone. So all these hormone producing tumors and or adrenal insufficiency can also result in diarrhea. So that was the secretory diarrhea. Now we come to the osmotic causes. Osmotic laxatives like magnesium and phosphate and sulfate. These are the osmotic diarrheal agents. Lactase and other disaccharide deficiencies. So if there is a specific lactase deficiency from the pancreatic secretions, then lactose intolerance, lactose will not get digested. It's a disaccharide. It can't get absorbed unless it is digested. So it remains in the gut, and lactase comes from, lactose is all milk proteins. They contain lactose. So disaccharide sucrose digestive enzymes, all these disaccharide digestive enzymes, if they're deficient, they will remain in the gut and generate osmotic pressure, make more secretions pour into the intestinal lumen from the secretory mucosa. Non-absorbable carbohydrates. These are not disaccharides, these are complex carbohydrates like sorbitol, lactulose, PEG, I forget the full form, but this is typically given for bowel preparation prior to colonoscopy. Okay. Some ethylene glucose or something like that it is, I forget the full. Polyethylene glycol, yeah, glycol, correct. Yes, I am. So this also can cause osmotic diarrhea. Then we have steatorial causes. I've already discussed in great detail. Intraluminal maldigestion because of either pancreatic exocrine insufficiency or bacterial overgrowth or liver diseases where bile, the emulsifier, is not coming into the gut. There may be intraluminal maldigestion, mucosal malabsorption, and post-mucosal obstruction, as in the form of primary or secondary lymphatic obstruction. And mucosal malabsorption is when the villi, the villi are ironed out, villi are atrophied. Then what will happen? Absorption will be less. Absorptive surface, which was like this, with villi finger-like. Now, if this is all ironed out, villi are atrophied, now you don't hardly have any absorptive surface. All those long fingers have gone off. So there will be mucosal malabsorption where you have celiac, Whipple, and certain infections. So you understood the steatorial causes? There could be, you can get a short note on steatorrhea. So intraluminal maldigestion, that's the contents, enzymes, bile. Mucosa, ironed out mucosa, atrophic mucosa, so many conditions. And post-mucosal, after the mucosa also, via the lymphatics, it is taken into the portal circulation and then into the liver for further processing the fatty acids. So, primary or secondary lymphatic obstructions. Could be tuberculosis, could be filariasis, so many causes are there. Now, the fourth cause we come to in inflammatory. Inflammatory causes, these two we are going to have separate lectures. Crohn's and ulcerative colitis. If we don't finish today's, we'll spill it into those because that is not so long. I've just kept 3 total lectures for your chronic diarrhea. So, inflammatory causes, inflammatory bowel disease, we are going to do separately. And then we have radiation injury in GI malignancies. That is also a big cause of chronic diarrhea. Food allergies. Food allergies. Some people have allergy to certain foods. The surface IgA comes into action. Some have peanut allergy, some have lactose intolerance, some have gluten intolerance. So those will come into these inflammatory causes. So gluten-free food can be prescribed. We will be coming to that eventually. And collagen vascular diseases. They will also cause vasculitis. Vasculitis leading to inflammation of the blood vessels supplying the gut. So many of the rheumatological conditions can result in inflammatory causes, and they are devastating for the poor patient. Immunological mucosal disorders can be there, infections can be there, chronic, I told you, cryptosporidium, immunocompromised people, chronic amoebiasis, bacteria, parasites. Need not only be HIV cases, others can also have chronic intestinal infections and inflammatory diarrheas, chronic diarrheas. But remember, this is a very small proportion of chronic diarrheas. These chronic infections, very uncommon cause of chronic diarrheas. By and large, chronic diarrheas are non-infectious. That is the basic message for you to become first-line practitioners. Then we come to the next one, which is dysmotility, motility disorders. Remember, we did achalasia of the esophagus, achalasia cardia. The motility disorders can affect Orbax and meandric plexuses, and or they may be other like visceral neuromyopathies, smooth muscle myopathies, or hyperthyroidism. That will also cause intestinal hurry through its autonomic, the sympathetic overactivity. Drugs, prokinetic agents, like some prokinetic agents, perinom, metoclopramide, these can cause even erythromycin, the first macrolide, also was known to cause excess motility, forward excess motility. There was a time when we were using erythromycin for forward motility, especially in the diabetic gastropathies. And diabetes itself can cause autonomic neuropathy and motility disturbances of the gut. And then earlier, for peptic ulcer, before we understood H. pylori and all this business, even in my lifetime, any and everybody with dyspepsia coming for more than 3-4 visits used to be worked up, and they would do a vagotomy. The vagus at the diaphragmatic entry into the abdomen used to be cut off. That was the truncal vagotomy. There were 2 vaga, they used to cut off both. After that, what will happen? What horrible things people did. This is after I became a doctor. People were still practicing vagotomies. Then they said, no, lot of motility disturbances, acid secretion stops, but motility disturbances are happening and patient's morbidity continues. It is not, from dyspepsia, he is now developing bowel disturbances. So they started doing selective vagotomy. The branch of the vagus supplying the stomach only, that they used to cut. Even then they had a lot of problems, bloating, because it was not just secretomotor. Vagus function was also smooth muscle motility function also. So not just secretory function, not just parasympathetic function, but also gut motility was controlled by the vagus. So then they started doing HSV, highly selective vagotomy. Gradually, GI has been taken away from the surgeon and it is being completely medically managed or endoscopically managed. Almost the entire GI. Very little role is left of surgery in GI, chronic GI disorders. Still, perforation, volvulus, these things still require a surgeon, ischemia, so many other acute emergencies of the abdomen. But chronic bowel disorders entirely managed by GE physician and endoscopist. So vagotomy is completely out now. Factitious causes. Factitious is fake, false. But factitious doesn't mean that patient is acting. No. Munchausen and eating disorders, they are deep-rooted psychiatric disturbances. Okay. So Munchausen is self-harm. Patient is patient is diseased. He's not pretending. Patient is diseased and is causing these things to themselves. This is a way of seeking attention, comfort. Those few days in hospital, at least 5 times a day, somebody is touching me. These are very lonely people, miserable in their loneliness, deep-seated childhood neglect, emotional neglect in childhood. So luckily in India, we don't have much of this. Every child is loved, cherished, and made to feel special. So it's a cultural thing. It's much more in the West. But yes, young women married off in their teens, uh, large joint families, neglect, husband is having multiple affairs. They are miserable. They don't know how to seek help and how to get out of it. So this becomes a coping mechanism to get out of home, get into the hospital. There are so many restrictions on traditional joint family sort of young wives and brides. नहीं जा सकते बाहर, बहू बाहर नहीं जा सकती. So those are the women who will come repeatedly for complaints with factitious chronic diarrheas. Be aware, and sometimes family counseling can go a long way, not drug therapy. Recognition is very important, not judging that she's good, bad, she's a pretender, she's not. No, she's distressed. May not be a problem in the gut, maybe in the mind, maybe in the psychosocial fabric of her environment. Then iatrogenic causes. Lots of people are these days undergoing bariatric surgery for weight reduction. Bariatric surgery, they put a big balloon in the stomach, or they may even do partial gastrectomy to reduce the stomach size. So satiety, the brain gets satisfied with lesser filling. A balloon is constantly giving the brain signal that I'm satisfied, I'm full. So this binge eating, munching, that all comes down, and patients lose weight very fast. But the problem with that bariatric surgery is, again, you're cutting off a portion of the stomach, you're going to have hurry. That may lead to chronic diarrhea. Cholecystectomy, same thing, because you will get more of bile is constantly pouring it. It is not coming into the gut in response to a meal, fatty meal, local release of cholecystokinin and the gallbladder contraction to empty out. There is no more reservoir. After cholecystectomy, bile is continuously trickling into the intestine. It doesn't have a storage bag. So those are the patients who would not have sufficient bile when the fatty meal comes. Bile is already gone ahead, and unutilized bile in the gut also causes motility disturbances, hurry, intestinal hurry. So bile initially will cause hurry, and when the fatty meal comes, there is inadequate bile, so again steatorrhea will follow. So in multiple ways, you can't just go, may develop a gallstone, so remove all the gallbladders. No, these days aggression is not the way forward for management of GI problems. Ileal resection, I have already explained why. The length is reduced, so the race finishes fast. Vagotomy, I have already explained. Fundoplication, this is also one of the surgeries done for hiatus hernia. The fundus is wrapped around the cardiac end of the stomach, and it is sutured. So again, the stomach capacity is reduced. So you've treated the hiatus hernia, but you've created chronic diarrhea. So even fundoplication is these days not being done very much. Better is to give the patient advice on meal timings related to lying down. At least 1.5 hours, that is stomach emptying time, you stay upright. After that, you can lie down. Then hiatus hernia will not cause any problem. So simple measures can sort out most problems, negating the need for these sort of drastic surgical measures. These days, nobody is doing. Abdomen, only in an emergency the surgeon is touching. Otherwise, medical management is the norm. So there are so many diseases of the small intestine causing chronic diarrhea and malabsorption. I've just listed a few. A few. This is enough for undergraduates. Celiac disease you should know about. Dermatitis herpetiformis. Yes, today you listen and after that you can forget about it. Tropical sprue. Celiac and tropical sprue are the two which I expect you to understand and know in detail. Also, IBS, irritable bowel syndrome. That little bit I will tell you about it because of Piku. You should understand because there is this sort of character in every family. Whipple's disease, small bowel bacterial overgrowth, ileal resection, short bowel syndrome, radiation enteritis. I think ileal resection, short bowel, surgeons will also explain to you in great detail. Radiation enteritis, proctocolitis also you can understand, you can guess, you can sort of build on it once you know the radiation destroys actively multiplying cells, and the mucosal cells are always in mitosis. Their rapid turnover is there because of constant friction with the contents. So we will be doing basically these two, and the others are just in passing, so that you understand. So chronic diarrhea and malabsorption. The first one is celiac disease. Anybody who has any idea, unmute and tell me. Unmute and tell me, what do you know about celiac disease? Do any of you have a family member? Yes, Hamza, excellent. It's very common, very, very common because diagnostics have improved, the tests have improved, so more and more people are getting diagnosed with celiac disease. Gliadin hypersensitivity, very good, excellent. So, and what are the things that we will not feed these patients? What is the food item that has to be stopped? Gluten. Yes, higher. Barley. Wheat. Yes, wheat, barley, rice. Not rice so much. Rice they can have. Rye. Yes, yes, Sapna. Yes, very good. I'm so happy to see that. Yes. Oat is wheat only. Oat is poha of wheat. That is oat. So most of you know. Very good. So it is now the definition. If you understand the definition, you can write your answer. It is immunologically mediated. It doesn't happen on its own. It is immunologically mediated. It is an inflammatory disorder. Immunologically mediated, inflammatory disorder, in genetically susceptible. So there are three things. There is immunological mediation. There is inflammation. Inflammation is the end point. Mediation is immunological. And the soil. What is the soil? It is a genetically susceptible. Genetic susceptibility, immunological mediation, and end result is inflammation. So it is, and this results from intolerance to one particular item in the food, that is gluten. Similar proteins found in wheat, rye, barley, and oats. Gluten, you gundo atta and you see the atta of a day old in the fridge. Take it out, let it come to room temperature. You'll find it gets sticky. That is the gluten. That is why atta rotis roll much better than bajra and makka. Makka also doesn't have much of gluten. So maize can be given to these patients as a substitute. And what is the result of this inflammation of the mucosa? There will be malabsorption. Simple. An inflamed mucosa will create malabsorption, diarrhea, and this condition, celiac disease definition, is not complete until you put a rider that it, yes, bajra is also used as a substrate, and it responds to a gluten-free diet. So with this, your definition is complete. Let us repeat it. Soil is genetically susceptible. Mechanisms, immunological, and the end result is inflammation. Fourth is it resulting from intolerance to gluten in the diet, resulting in malabsorption. And when you take away the gluten, it subsides. So, response to a gluten-free diet. All these 6 are important in understanding the celiac disease. If you remember the definition, you can build upon it so easy. Worldwide prevalence, more in Northern Europe. 50% cases are asymptomatic. So we have anti-gliadin antibodies positive with no symptoms of diarrhea and malabsorption. Undiagnosed silent cases. Latent celiacs may be there and they may develop later. So this anti-gliadin antibody, if you do in symptom-free people, you're going to get a lot of positives. Screening if you do, and all of them don't need gluten-free diet. So presence of anti-gliadin antibody in the setting of chronic diarrhea clinches the diagnosis. And in these cases, the antibody titers can be used for improvement, to follow up these cases for improvement. But somebody who doesn't have symptoms and you have an anti-gliadin positivity, it doesn't mean that you start cutting off the gluten in their diet. Because along with gluten containing food, that food contains so many other things, carbs, minerals, nutrients. You can't just deny somebody regular food. So you must understand that 50% of those who are anti-gliadin positive are asymptomatic and they do not require intervention. They may at a later date develop. That is the time you will intervene. Precise mechanism of mucosal damage still remains unclear. There is an immunological response to gluten which plays the key role. You have 2 things. TTG, this is an autoantigen. Tissue transglutaminase. Okay, so this digests the tissue transglutamic acid. So tissue transglutaminase and anti-endomysial antibody. TTG is itself an enzyme that you can detect, and endomysial, this is used for muscularis mucosa. Okay, so there is a myo component, there is endo component. So it is the muscularis mucosa antibodies. This is used in serological diagnosis. It's not done on tissue biopsy of the gut, it is done in the blood, serum. Okay, serum will pick up these 2, one antigen and one antibody. These are the 2 common tests which we do to confirm celiac disease in the setting of symptoms, in the setting of genetic history, that more family members have this problem. So all that put together, if they are positive, then we make a diagnosis of celiac. So celiac in children and adults, how will it differ? Somebody unmute and tell me. I'm making it big. I can see you. I can see all your chats now. In children and adults, how will it be different? Chronic diarrhea in children versus chronic diarrhea in adults. What is the basic difference in children and adults? Common sense. This is just common sense. Somebody? Nobody? One good response I want. Yes, Pankaj. The growth. Children are yet linear growth. They have to still grow tall. So linear growth in children is affected if celiac happens in childhood. That is the basic difference. So children can be affected at any age. Growth and pubertal delay. Short stature in adulthood, if it starts in childhood. In adults, so any growth retardation child in pediatrics, they will tell you screening for celiac, lactose intolerance, celiac. These are the things that you should sort of screen growth retarded children and send them to the pediatrician or whatever, and I get these tests done. No other cause is there, no malnutrition, affluent families, no primary complex, nothing is there. Why this child growth is not there percentile wise? It's at the lowest level of the percentile, so they should be considered for these investigations. In adults, growth is finished. So the peak age is roughly 50s, females a little more than males. Clinical features depend on the severity and extent. Both. Severity is how severe is the inflammation, extent is how much of the bowel is inflamed. So one is intensity of infection, and the other is inflammation, and the other is the stretch of the inflammation. So obviously, the more severe and the more extensive, you will have more symptoms. Fluoride malabsorption will be there in some or non-specific symptoms. Some may not have full-blown malabsorption of all nutrients. They may have just non-specific symptoms of tiredness, weight loss, unhappy abdomen, grumblings of the abdomen, erratic bowel movements, folate and iron deficiency if it's been long standing. Folate has no body stores, so folate deficiency amongst micronutrients is one of the first to manifest, and you'll see it as a macrocytosis on peripheral blood smear. Iron deficiency also, they may have anemia, so you may have mixed dimorphic anemias. Okay. Oral ulceration, because mucosal integrity is also dependent on many micronutrients. Dyspepsia, bloating, so many abdominal non-specific complaints may be there. Fluoride, complete malabsorption will be there, whereas milder cases will have these variable micronutrient deficiencies, general malaise, weight loss, uncomfortable or local symptoms of the abdomen in the form of dyspepsia, mouth ulcer, bloating, that sort of thing. Associations. What are the associations of this celiac disease? Other HLA-linked autoimmune disorders, like so many are there. When we do rheumatology, we'll come to, and certain other diseases. So linkage is there with HLA type. There are linkages with type 1 diabetes, that is the mutation related, not the inherited form. If there is a mutation, some of these celiacs will have type 1 diabetes, especially the childhood celiacs. Thyroid disease in 5%. Primary biliary cirrhosis, this is also immunological, 3%. Sjogren's syndromes, keratoconjunctivitis sicca, dry eyes, dry mouth. So all these exocrine glands are getting fibrosed and secreting less. IgA deficiency may be seen, the surface antibodies in about 2%. Pernicious anemia, we've just done pernicious anemia, is seen in and as an association with celiac disease. Inflammatory bowel disease, that is the ulcerative colitis, Crohn's, may also be associated. All these are immunological disorders. Sarcoidosis, myasthenia gravis, neurological diseases like cerebellar atrophy, peripheral neuropathies, immunological epilepsy. These are celiac, they're well educated people, so their self-help groups extend across continents. It's a very rich society, celiac society, and so that is why much more is known. We don't know so much about leprosy, we don't know so much about Chagas disease, we don't know so much about leishmaniasis, because they all happen amongst poor people who don't have money and they don't have such a lot of self-help groups. So these are all rich man's diseases, and lots of data is being generated because activism. There is some amount of activism, put pressure on scientists to work here because funding, grants. Nobody wants to research helminthiasis But people want to research celiac because there is a lot of money in celiac. People can live a lifetime doing celiac disease research. You will always have so many foundations funding you. Dermatitis herpetiformis, Down syndrome, enteropathy-associated T-cell lymphoma, small bowel carcinoma, squamous carcinoma of esophagus, ulcerative jejunitis, pancreatic insufficiency, microscopic colitis, splenic atrophy. Look at the list of associations that has been researched and established. Okay, so remember, the rich man's disease has lot of takers even in the scientific community. Nobody wants to research. Underfunded, chronically underfunded are these neglected diseases. Okay. So two things have to be done in celiac. One is you confirm the diagnosis, and the second thing you do is tests for malabsorption that will follow. Okay. So two things. How do you confirm diagnosis, and how do you do, what are the tests that you will do for malabsorption? I've taken celiac as a prototype. It applies to all. So you can build and make answers to almost all the conditions based on this class. So confirmation of diagnosis, duodenal or jejunal biopsy is the gold standard. Histology characteristically shows villus atrophy. Sometimes the villi may appear normal, only increase in intraepithelial lymphocytes. So there will be a lot of unusual amount of lymphocytes in the tissue. Lot of so there is a chronic inflammatory response in the villi. Extreme, you may get villus atrophy. Short of villus atrophy, this inflammatory response is also the gold standard. Gold standard means this is the confirmatory test. This is the absolute end point of the proof of the pudding is in the eating. So this is the eating part. You have made a histological diagnosis, villus atrophy and lymphocytic infiltration. Now, we do a lot of surrogate tests. Every patient, we don't need to do this histology because all other tests which came up later are benchmarked against this, against the gold standard of histology, and then we say how specificity and sensitivity of that new test that emerged is always benchmarked during its development and research against the gold standard of jejunal villus biopsy. Okay, so this is the gold standard. And consequent tests for malabsorption, fecal fat, fecal glucose testing, so many. Malabsorption will lead to so many changes. And nutritional deficient B12, folate, thiamine levels, iron levels, ferritin, TIBC, all this will tell you whether there is malabsorption. Other causes of villus atrophy are very important to exclude because we said villus atrophy is the gold standard. So what else can cause villus atrophy? We should know. So tropical sprue, dermatitis herpetiformis, lymphoma, AIDS enteropathy, giardiasis, hypogammaglobulinemia, radiation, Whipple's disease, and Zollinger-Ellison syndrome. That is the gastrin. Lots of gastrin is there. So these are the other conditions that need to be excluded before you talk about celiac disease or say this villus atrophy is because of celiac. In confirmation of diagnosis, one was villus atrophy, biopsy, jejunal biopsy. Second is antibody detection. It's a good screening tool. It's not a substitute for biopsy. It's negative with successful treatment. So there are two antibodies is serum anti-gliadin antibodies, IgA and IgG, and anti-endomysial antibodies. Okay, so these two are the antibodies. And there is an antigen detection which is easier, more accurate, that is tissue transglutamase assay. How much is this enzyme circulating in the blood? Okay, TTG is raised, and we know that celiac is there, and it is raised along with these two. Celiac is there, but all are raised without symptoms for treatment. All are raised with symptoms. Diagnosis, you may be able to skip jejunal biopsy. Jejunal biopsy positive with these negative, think of the other causes of villus atrophy. Jejunal biopsy, villus atrophy, without these, with these. So it's a little complex, enough for undergraduates to understand diagnosis of celiac is not so straightforward. Then the next thing that we come, test for malabsorptions, very simple. Dimorphic anemias, features of hyposplenism, that means you see a lot of disordered RBCs, target cells, pherocytes, Howell-Jolly bodies. Biochemical tests will show all low. Serum calcium low, magnesium is low, total protein low, albumin low, vitamin D low. So tests for malabsorption are so many. Absorption nahi hua to. These are all items which are absorbed from the gut. So treatment, you will correct all the deficiencies, iron, folate, calcium, vitamin D, minerals, and lifelong gluten-free diet. What is not allowed? Wheat, rye, barley, and oats. They may be introduced later once the symptoms subside, only to be withdrawn when the symptoms recur. What is allowed? Rice, maize, potatoes to provide the complex carbohydrates. People need calories, and easiest calories come from carbohydrates. You can't completely restrict carbohydrate of anybody's diet. Frequent dietary counseling, because once the patient starts feeling better, चलो आज आधी रोटी खा के देख लेते हैं, कल सूजी का हलवा खा लेते हैं, परसों दलिया खा लेते हैं. So कुछ नहीं हुआ, लेते रहो. So frequent dietary counseling, reminder, and आज खाया तो आज शाम को diarrhea हुआ, ऐसा नहीं होता है. It is after a couple of days once the antibody mediated inflammatory response sets in. So it may be a week ago that you took the patient took gluten in the diet. Week later the symptoms may start. So the patient mentally doesn't connect कि उसकी वजह से ऐसे हुआ, कुछ दिन के बाद हुआ. So you have to keep reminding them that the main reason for failure to improve is that the symptoms follow a couple of days after the dietary indiscretion. Educational booklets, diet sheets, recipes, so many things can be done for celiac disease cases. Third thing we do in the management is monitor symptoms, weight, and nutrition. And 4, repeat jejunal biopsy. If there is no improvement, or if there is persistent antibody positivity, either the patient is cheating on the diet or there is some other condition. Okay. Refractory cases which don't respond to all this dietary manipulation, then corticosteroids, immunosuppressants may be required. Reassessment for dietary compliance may be required. Exclude other conditions like pancreatic insufficiency, microscopic colitis. That is a specialized field. Look for complications of celiac disease like ulcerative jejunitis, enteropathy associated T-cell lymphoma. These are all more for gastroenterologists, not so much for undergraduates. Complications are malignancy, ulcerative jejunoileitis, and the course of this ulcerative jejunoileitis is progressive, relentless. Metabolic bone disease, because of the vitamin D and calcium metabolic problems, you can have a metabolic bone disease. Osteoporosis, osteopenia, so many things. So with celiac I have finished. I think I'll stop here. Best is to stop when reception is intact. We are comfortable on lectures. I've kept two more So we will take them up, and ulcerative colitis, Crohn's. Once these are done well, you will be absolutely comfortable. That lecture will go through very quickly. Okay. So with this, I think I will stop. It's good to stop when people are still responding. And yeah, I like teaching your batch. You people respond. Let me first stop the recording, and then we can chat. Okay, I've stopped the recording. Now you can tell me. Unmute and